Charlene. I'm a dietitian working in child and adolescent eating disorder services. Have worked in dietetics now since 2013 and worked in an eating disorder since 2015.
Hi, I'm Fiona Bullivant. I'm an advanced nurse practitioner, learning disability nurse by background. Currently working in CAMS with young people with autism, learning disabilities and additional mental health difficulties, and have been in the CAMS service in relation to that for the past 12 years.
Some of the things that we're going to talk about today is based on our book that was published in July, Autism and Eating Disorders. I suppose initially we just want to give some background information on that. So in terms of what we'll cover today is the challenges in terms of kind of what we meet in presentation, why kind of autism is never kind of identified, what's needed in early identification, in terms of therapy and intervention, with a real strong emphasis that one size does not fit all. What we find is a lot of treatment and interventions, especially within the eating disorder world, is actually very manualized, and actually these don't work with our kids who may also have autism. We'll also cover recovery and understanding of self, just in the context of the eating disorders and the autism. And then we'll talk briefly about other things that we might need to consider when we've got young people in front of us. And then we'll kind of wrap up in terms of our general advice for professionals and for parents. So in terms of background, there's very little information on the prevalence of autism and eating disorders. And when eating disorders kind of covers an umbrella of terms. The most commonly known are anorexia nervosa, bulimia nervosa, binge eating disorder, and other ones called either OSPED or EDNOS, which is like eating disorder not otherwise specified. Most of the research in terms of the link between autism and eating disorders is usually with anorexia nervosa. And just to kind of define anorexia nervosa, it is restrictive eating with a view to lose weight or a fear of gaining weight or being fat, alongside kind of a distorted view of themselves. These are what we call eating disorder cognitions, and you will see that this may look a little bit different in those with autism. So some researchers that we commonly know in this field have kind of cited that maybe within the kind of eating disorder community, about 1 in 5 have autism. And actually anorexia has been coined as the female Asperger's. Also in the research, it's kind of saying that there's an overrepresentation of autism in kind of those with anorexia nervosa, and they have poorer treatment outcomes, higher illness severity, and a longer illness duration. There's also been a hypothesis that maybe we should explore autism in those who've got SEED, so that's a severe and enduring eating disorder. So they tend to be in services for a really long time, several years, in fact, and kind of tend to be in and out of inpatient services. So what we're saying is that actually in females especially, autism is misunderstood and rarely identified in their early years. And it actually may be an eating disorder that brings them to our clinical attention. And that's actually what we're finding in our own practice, that they get to their transition years and then they suddenly appear in our service. And actually there's been a lot of kind of red flag moments throughout their life that may have highlighted that they were having difficulties beforehand. So just to kind of cover what the challenges are in terms of kind of identifying autism in those who've got eating disorders. So there's the treat versus state conundrum. And what that means is whenever you're starved, regardless if you have an eating disorder or not, if you or I were restricting our intake, we actually become really rigid. We also tend to not show any empathy when we're starved. We also develop an obsessionality or preoccupation with food, and that's just an evolutionary adaptation. So if we are not getting enough food, then our thoughts will start to ruminate about food in order to kind of seek it out and to nourish ourselves. What we also find within females is masking. So that's basically they're able to adopt a different position, and actually you can't see any differences, and they've been so used to this that whenever they come into sessions for assessments or any of that, then they put that mask on, and therefore it can be very difficult to kind of pick out. I also want to put a word out there about social conditioning and diet culture. I think all of us are subjected to this and unbeknownst to ourselves. So especially now through the January period, there's a lot about we need to lose weight, we need to eat less. It's on every board as I travel to work, it's on TV, it's on social media, and actually this does have an influence on us. So what does that mean for those who have autism, who may have some obsessional characteristics and also may be rigid? So if they get this information drip fed to them every single day subconsciously, then it will have an influence on their everyday functioning. Again, practitioner and knowledge and training. So what we find, especially as we work together, is that we know very little about each other. So eating disorders know very little about autism, and those working in autism know very little about eating disorders. And that's even me and Fiona before we even met. And it's important to consider that actually what we don't know is what we don't know, but we need to kind of test ourselves to kind of venture into that land, to kind of be more open to that kind of learning, because it will actually enhance patient care. And again, just to reiterate, services are often very separate. Fiona and I are very lucky, we work in the same building, but actually sometimes that's not even happening. We're in very separate buildings across maybe a large area, so we don't have those conversations that are really important. Okay.
I'm just going to talk a little bit now about early identification, and what we mean by that is when we meet our young people in CAMS. So rather than thinking about early identification when they're young, which we know would be the ideal really, and which is what, you know, as clinicians we're striving for, in hope that eventually we'll have the services and the provisions in place that, you know, we can have young people identified at a really early age, so that then we can, you know, implement the strategies we need to implement. So hopefully they wouldn't get into the position of needing to be seen by us in CAMS. However, we're not in that position yet. So for the purpose of the discussion today, it's about early identification when we see those young people in CAMS. So what we know is crucial is a developmental history. I'll go on to talk about that in the next slide, as well as the sensory needs. If we just talk a little bit now about cognitive and communication difficulties. So in terms of cognitive differences, we know that you know, all of us are individuals, but we do know that our young people that we see often have differences in the way that they process things, the way that they interpret things, the way that they manage how they interpret certain things. So, you know, we need to be really mindful of that, because a lot of the young people that we see in front of us are, you know, highly articulate, have very good language, and have learnt, as Charlene was describing, to mask as well. So it's often really deceptive. You know, they're deceptive in terms of, you know, what they're struggling with. So it's really important to be kind of aware of that, and to kind of look for that and dig a little bit deeper into the kind of cognitive issues. So when I'm talking about that, we need to think, you know, of other things like dyscalculia, dyslexia, dyspraxia, be mindful of executive function difficulties, and have a look as well at those. The same goes for, you know, communication. Just because our young people have a lot of language and can hold a conversation and can talk at length, perhaps, you know, and have a very adult conversation with us, it's really important that we kind of look at the flavour and the quality of that and the depth of it. So an example of that would be like reciprocity. So is there reciprocity in a conversation? There's many times when I've done ADOSs with our young women, and they've learnt, because they've been parented really well, and because they've, you know, they've learnt along the way to mask, and they've copied, that they know to ask questions. So you'll often be in the ADOS, and you'll be thinking you're engaging in a really quality kind of conversation, but actually what's happening is they're doing it by rote. So you have to kind of go into that in more depth and watch for whether they're actually interested or not. So, you know, if I'm talking about I like dogs and they have a special interest in dogs, you might get a bit of a flow of conversation. But actually, if you take them a little bit off piste, you might find that actually then they start to kind of like, you know, wobble a little bit and don't know how to cope with the unexpectedness and don't know how to show an interest in you. Even though they might want to do that, they might really struggle in terms of their communication skills to cope with all of that and continue a conversation. So reciprocity is a real key to difficulties in that area. Not being able to sustain a conversation when unpredictability is thrown in is another key area. Very, very complex area, and I would always again look towards, you know, speech and language therapists to help us with that area, because again it can be really, really difficult to pinpoint what's actually going on. But if you have a specialist, you know, having a look at those, and specifically not just a generic speech and language assessment, but a very specific one in relation to autism. Relationship with food, I'll let Charlene speak on a little bit. She'll come to that a little bit later. That's more of her expertise. We just dig a little bit deeper into developmental history then. So a lot of our young women will come to us, you know, from the ages of probably like 10, more likely 13, 14, 15, and will have sometimes have been in services before, sometimes won't. It'll be a first presentation. What we know is that they often come with no developmental history, or not a very rich one, and certainly not one that we would do in the world of autism, in terms of what we really kind of dig down and delve around and ask questions around. So sleep is really important in terms of whether they could go to sleep, whether they could stay asleep, how they slept when they were children, how they've managed, what strategies they use to sleep, and look at whether they're unusual strategies, whether they're still real struggling, because we know the developmental stages of children. So, you know, you've got a bit of a benchmark there to kind of give you a clue to what, you know, whether there's a difficulty or not. So really have a look at that, you know, whether they still need people to reassure them to go to sleep in their teens, or whether they need objects or strategies, regimes, rituals in order to get to sleep. Eating and drinking, again, from my perspective, and Charlene will talk a little bit about her area of expertise in relation to this, but what I'd be looking for in developmental history is the transition from breast to solids, whether that was possible, how they managed, if they were bottle fed, did they have to have particular teats, really kind of, you know, that did they bond when they were being fed by whoever they were being fed by? Did they give eye contact? Did it feel warm? Did it feel like a relationship? And whether there were any unusual patterns in the behaviour, whether there were particular things that they liked to eat, whether they avoided certain textures, whether the aesthetics of the plate when they're eating or the environment was unusual, you know, in relation to other children at those developmental stages. Same kind of goes for friendships and relationships. You know, we know children go through different stages of being perhaps a bit clingy and not liking to separate, but actually, if you look at the flavour of kind of a friendship and a relationship, you know, was it alongside the other young children? Is it domineering? Is it copying? Or is there reciprocity again in those relationships? Did they know how to make friends, how to sustain friends, how to mend friendships and relationships when they went wrong? Or did they need a lot of scaffolding around that and continue to need a lot of scaffolding? Did they learn by mistakes? Were they able to reflect on what their part and responsibility was in a relationship and a friendship? So really looking at, you know, did they have more than one friend? What did a best friend mean to them? You know, the intensity and quality of those relationships as well, and whether they showed empathy within those relationships, and how they managed when they lost the relationships or there were difficulties. So talked a little bit about language and communication before. So again, just, you know, did the young person speak at the right milestones? Did they speak early? Were they really late? How did they speak? Did they just speak and then could have a conversation, which as some children do? And whether again they showed, you know, that kind of interest in other people in relation to their communication skills. Empathy, there's kind of like a myth been around for a long time that our young people don't have empathy who have autism. we know they do have empathy. There's again, like any of us, you know, some of us show empathy more sometimes than others, but often what we find is that they'll over empathize or not be able to communicate how they're feeling or know how they're feeling to then be able to communicate it. So there's often a lot of holding other people's emotions and situations, not knowing what to do with them, not knowing how to communicate it back to that person or others around them. So they sit holding, so they hold their worries and thoughts about what's going on and perhaps struggle with understanding that, but holding other people's thoughts, behaviours, etc. So there's a real kind of like double element to that, and a struggle to communicate how they're feeling about that. Behaviour, we know, is a communication. So if you have young people that, you know, the parents are reporting to you that you know, they headbanged when they were little, they spun, they paced, they had self-injurious behaviour, they wrapped themselves, etc. Really take note of that and look at the developmental milestones again, and, you know, whether it was appropriate or whether it's continued, in what context is it, are they able to manage it, and really think of it in terms of what they're communicating and at what times they were doing these behaviours. So what was happening at the time, what was the function of that behaviour, really important, what was the function of it. Again, look at, you know, we hear of, you know, the stereotypical kind of things of little boys, you know, lining up Thomas the Tank Engine in cars, and girls collecting teddies, etc. You know, look at the actual what they were doing and what it was doing for them. It links with collecting as well. So look at, like, the, you know, even if they were being really quite stereotypical and it was collecting dolls or teddies, what was the intensity behind it again? So if people took them away or moved them or weren't allowed to have them, how did they manage that? You know, what was the function of that obsessionality? And it's not just in terms of behavior, it's in terms of thinking as well. So, you know, do the young people ruminate a lot? Do they overthink? Do they have to process a lot time and time again? So you know, whether there's any particular rituals or routines, you know, I've got to do this so many times, or I've got to do it in a certain way, and often that you know, we can kind of get offered a tangent for it being kind of an OCD behaviour. Now, it can be OCD and autism, but it can sometimes just be the obsessional thinking in relation to autism. So again, more digging and delving. If you know that you've got somebody that is struggling with that kind of thing, try and find out where it's coming from, where the root's coming from. Transitions. So when we're thinking in terms of developmental history, you know, how did they move through the school year? Did they cope? How did they cope with separating from people during those transitions? Did they need objects to help them transition? So, you know, I had a young lady once that always needed a pebble through primary school. We had terrible, you know, times understanding why she was so distressed at times, and it would be perhaps if she'd forgotten to bring her pebble, or she couldn't have it in a certain lesson, or she'd misplaced it. So again, you know, looking at those different ways of trying to manage and regulate emotions, see what kind of systems they have in place and what kind of strategies they've had in place to help them, and that'll give you some clues as to, you know, where the origin is of the behaviours. So I think that's all for developmental history. So in terms of the sensory, we know we're, you know, all of us are sensory beings, but we know that perhaps the sensory integration and processing issues, that there can be issues with that with people with autism. And in terms of arousal levels, they can be either under aroused or over aroused, and actually that can really impact on their emotional well-being and how they regulate themselves. So we know that if you're over aroused, you're less likely to probably be able to calm yourself down. But then if you're under aroused, you might need really revving up to respond to something, so you might seem quite low, and on the other hand, you might seem quite, you know, hyperactive. So it's worth bearing in mind in terms of kind of arousal levels as well. If you are looking at you know, you've got a young person in front of you and they're reporting lots of needing to move and activity and agitation, you know, have a look at why that is, whether they're under aroused and they're seeking. But also bear in mind as well that we'll come on to a little bit later, you know, think about ADHD and that as well, because that is an area that we've really missed at times for our young people. And again, it presents differently in our girls. So just, you know, kind of keep that in mind as well. In terms of, you know, lots can be done in terms of sensory diets to help our young people. But again, I would be looking to the occupational therapist. I'd be looking for their specialist advice in terms of sensory assessments, etc., to really understand what's going on for that young person, and then it being able to give them a sensory diet and them to be able to implement that into their day, learn then through their sensory needs how they can manage their emotions. You know, it's just another element of understanding themselves which can really help self-regulation. I'll let Charlene talk about feeling full, etc. And again, I'll let Charlene talk about mealtime environment. That's kind of her thing.
Sorry, Fiona, I realised that I accidentally deleted sensory diets from this slide.
That's all right.
Okay, if we move on to kind of the relationship with food and weight, I suppose a lot of this has been covered by Fiona in terms of developmental history. I suppose in terms of kind of the feeling full and not knowing when to stop eating, they're completely two different things. But I suppose what we really need to kind of understand is the context of that, the feeling full. For example, a lot of people, whenever they're refeeding, will feel uncomfortably full, but those with autism, that's a lot more heightened, and it's understanding that it could be painful at a very extreme level, really strong discomfort. And we actually had one young person who was vomiting, and we just assumed that that was part of an eating disorder behavior, but actually it was because of the sensory aspect of the refeeding and that kind of really uncomfortable feeling of feeling full, and actually it would just kind of cause spontaneous vomiting. It wasn't actually self-induced vomiting. I also assess in terms of my dietetic assessment to look at all the senses, just like Fee kind of covered why it's important. So that's like taste, smell, sound. So a lot of young people are distressed at meal times, and again the context is really, really important again. So is it distress because of the thoughts that they're having in terms of the food that they're eating and the fear of gaining weight, or is it distress because there's noise going around? Is it like the kitchen's too busy, the dining room's too busy, people eating, bright lights, all those things, because they can also cause meltdowns and distress. So it's understanding the difference. Because sometimes we just go, oh, were they distressed at mealtime? To go, yeah, there's a lot of screaming and shouting, and we don't understand the context of the behavior, and it's really important to kind of know the difference. It's also establishing the history of preferred foods and reasons why. The reasons, like for what they ate beforehand, was it what were really commonly known as the beige diet, and then suddenly they started eating kind of all the salad options, which is out of character. So why have they gained that information? How come that's established? Why are they previously eating quite a bland beige diet and now have moved towards, I'll always put this in inverted commas, healthy diet? Also consider culture and tradition within that family. So sometimes we kind of look at the history of eating and what's being eaten, and family goes, oh, no problems at all. But sometimes we've got to remember that sometimes parents also have a difficult relationship with food, or actually it's their preferred foods become the child's preferred foods, and maybe actually autism might be in play with the parents. So it's really unpicking actually what's family meal times like, what are they eating, what's kind of very traditional within their families. It's also really important to distinguish between preoccupation and a special interest. So preoccupation is around for us all when we're starved. This preoccupation will alleviate as we re-nourish our bodies. In those with kind of classical anorexia nervosa, this preoccupation will move and shift and will disappear in between meal times. The cognition, gaining weight and not liking food will still be around at meal times, but will lessen. In those with autism, it might be kind of still there all day. There might be lots of kind of watching kind of bake-offs, wanting to cook, doing all those things as they re-nourish. So those without autism will tend to do that when they're starved, but as they re-nourish, that becomes reduced. In those autism, it still stays because it's become a special interest and they're really kind of obsessional about it. I've already kind of covered about context of behaviours, but one thing to kind of highlight is that we've had a young person who, when getting weighed, keeps saying, I want my weight to go down, I want my weight to go down, which is not unusual in the eating disorder world. But whenever we started to really unpick that, it actually wasn't about how she looked and weight actually physically reducing. It was actually about the numbers going down on the scales. So it was actually an obsessionality about the numbers and them going down. So she quite liked just seeing the numbers going down. Also in terms of calorie counting, so we often just go, oh, do you calorie count? Yes. Oh, what's your number? And they have a number. And we just link that automatically to go, oh, that's to kind of manage their weight. But again, it could be obsessionality around numbers and not necessarily how they look. So that's the kind of real differentiations between kind of those without autism, those with autism. It's important to see the difference between I feel fat and I do not want to be fat. So in terms of people with kind of anorexia, you usually see that they believe that they are fat. So they could be significantly underweight, but they will see themselves in the mirror as completely different. What my kind of understanding sometimes with those with autism is that they can see that they are not fat in the mirror, but still don't want to be fat. And that's going back to what I previously talked about in terms of our social conditioning around diet culture. So again, it's about their peers because of transitions and wanting to fit in, and you've got your friends talking about diets and wanting to look like a certain way, then they can start developing that language as well. So it's important to pick out the differences.
Okay, so just a little bit about therapy interventions and the real major thing that one size does not fit all. These are individuals, our young people are individuals, and we need to understand that and not pigeonhole them. Saying that, there are certain things that we kind of need to do, but we need to understand our young people before we kind of recommend anything or start to implement anything. Just having a label coming in of saying, oh yeah, we think this person has an eating disorder and we think they need this and this. No, we need to know a lot more about them. We need a much more holistic approach and a bespoke approach, to be fair, and multifaceted. So when we're looking at the therapies and interventions, when eating disorders have had eating disorder teams have had particular ways, and is it, Charlene, that you describe it as quite manualized, the ways that you work with your families, and in the world of autism and the way that I work, that's like the other end of the spectrum. So very bespoke, we normally work, and very person-centered and led on what we know about the young person. So trying to marry the two together, as Charlene was kind of talking about before, about how we then as clinicians understand our young people and how we then flexibly work with our young people. So this again is about listening to what they're telling us, looking and delving into what we know about them, and then thinking about what is going to work for them. So we can use our evidence-based practice, all the for example, so we may need to use something like CBT if we've got a lot of obsessionality there, or if we've got some trauma in there, but it may be that we need to think about how we implement the interventions and the therapeutic modality, and so that whole thing about working together and understanding each other's kind of skill sets and mixing and matching that. So that's a bit like how Charlene and I work. So if Charlene is presented with a young person and thinks there may be autism, or we know that autism has been diagnosed, often we'll have a consultation, and then it may be that I go into the session and then we start really picking out where the therapy needs to go and how we manage that and how we do that. So that's really really important. And again, going back to, you know, use your colleagues as well. So this is around, you know, not just having one pathway and one way of working. It may be that, you know, we've got a young person that has got an eating disorder, has got autism. We need to have OT on board, we need to have speech and language on board, we need ed psych on board, we need psychology on board, we need systemic practitioners on board. So that whole kind of wraparound service to kind of help them, but with that fundamental understanding that the driver may be coming from the difficulties from what they experience from having autism. So you know, being really mindful of what we've talked about before and adapting your practice. Be flexible as clinicians. You know, clinicians being rigid is not going to be helpful, is it? You know, if we're working with young people who are also perhaps exhibiting, you know, severe anxiety, low mood, and struggling with how they manage us and understand us, it's our job, as I always say, to go into their world. It's not their job to come into ours yet. Our job is also to go into their world to enable them to manage the world that we live in, but not to kind of expect them to just fit into our ways of working. We've got to understand and be adapt and be flexible, and knowing the function of why they are experiencing what they're experiencing, you know, why they're communicating in the way that they are, why they're perhaps presenting with some behaviours that we don't understand, and for them to struggle to tell us that's not their issue, it's ours. We should be working really hard to try and find out what the function of that is, and again, that comes back to everybody kind of really trying to understand this person. In that is that really important, you know, thing of having your main person who is that therapeutic relationship with them, who then can kind of guide everybody else and bring in those other people when they need them. So that real holistic wraparound kind of way of thinking. Which is just what I've talked about. So yeah, just going on a little bit about the therapeutic relationship, we all know that's really, really important. So not to be scared as well, if, you know, sometimes as clinicians we think we have to keep on going, you know, if we just try this, if we just try that. Actually, if we're really open and honest and transparent and the relationship isn't working for whatever reason, you know, hopefully then we can have a, you know, a really good conversation about that and think about whether, you know, a clinician needs to change or whether we just need to change tack. But being honest and reviewing regularly is really, really important. So which means brings me on to time. So, you know, we often talk about episodic pieces of work. Well, often these are not short pieces of work, and that's not because we don't review and reflect and shift all the time. We do, but it may be that it's just we just need more time. We need more time to build that relationship up. We need to build up trust. We need to build our knowledge up. We need to try a few things and restart. So often, you know, a lot of the arguments kind of I have are, I need more time. I need more time to understand and to implement. So don't be frightened of that either. You know, don't just kind of crack on or don't just hold back. Really use your clinical skill to think about, you know, why is it taking more time, and why you need more time. I talked again before, you know, work together as teams, talk to people, be open with your young person that you are sharing information as well, and that, you know, why you're sharing that, and it's important. Often our young people don't want us to kind of talk to school, or because, you know, I'm really clever at school, I don't want them to think I've got a problem. So it's that whole kind of like thinking about what autism means, and actually it's a different way of thinking. It's not a problem, but a lot of our young people have kind of ideas in their head of what autism is, and a lot of them don't want other people to think that they might have, you know, a diagnosis of that. So it's again thinking about all the time about that way of how you communicate what autism is, and that to all the clinicians to be thinking of that. So that's where, you know, training for all the clinicians comes in as well. We talked a little bit, you know, go into their world, don't expect them to come into yours, and be really flexible.
I suppose one of the things whenever you're working with someone with restrictive eating habits, people are a bit anxious around the time bit because they're very aware of the physical health risks. And I suppose sometimes we can get over-consumed by that. So when we're in a session with a young person, we get really kind of, ourselves as practitioners get kind of go into kind of crisis management. But actually that means that we're taking away from the time and holding space for that young person, because sometimes all they need is to be felt, to be heard. And actually that can really make a difference. So even though it may feel like actually I've got a young person and they're eating nothing and they're, you know, like physically they're not doing well, their session is still their session, and it's holding that space for them and then managing all the other physical health parameters outside of their one-to-one session. I suppose in terms of recovery and understanding of self, I just want to kind of highlight recoveries in terms of the eating difficulties, not in terms of autism, because recovery of autism isn't a thing. And I suppose when I say about diagnosis and labels, what we often find whenever these young people present to our services, they may already have come with lots of labels: depression, anxiety, OCD, and now an eating disorder. And I think sometimes as practitioners, we have to sit back and go, oh, how come this young person has all these kind of diagnoses? What's kind of going on from them? Is there something a little bit different? What we often find in kind of our community, whenever they do get a diagnosis of autism, it suddenly falls into place. It makes sense for them. So instead of all the multiple kind of labels and diagnoses of everything else, autism kind of goes, actually that sits a lot better with me. It makes me understand myself a little bit better. Recovery doesn't actually have a defined definition, believe it or not. And I think it's really important to capture patient experience and what they think recovery is. What does it look like to them? What do they want to achieve? So regardless of autism there or not, I think involving the young person and their family on what they would look like without these eating difficulties around. We're never saying that they're going to recover from their obsessionality or their rigidity. That's always going to be there, but how can we make sure that it doesn't impact on their physical health going forward, and use it as a more useful resource? Just like in terms of the counting numbers that I mentioned earlier, this young person was counting down the words, and then actually we did some time together, and believe it or not, we had to sit in the same seats in the same room week on week in order for us to build that therapeutic relationship, to turn it around and count the numbers up the way. So it was just working on that. So she was still counting, which is something I never usually advocate among my young people, because I don't want to kind of make more rigidity, but this is completely different when there's autism at play. Actually, this build in your love of numbers to go the other way, and together we'll do it. Also about terms of recovery, if a young person presents with an eating disorder, maybe there's autism at play, is it because this is the only way that they could communicate to us that there's a difficulty? I'm struggling, I don't understand, why do I not understand the world I'm in? So actually we need to work on young people to find alternative means of kind of expressing themselves, how to regulate their emotions, actually and how to highlight to others, actually I'm at difficulty here, but I don't want to go to my coping mechanism of restricting to eat. So these are all things that we need to kind of consider when we're talking about recovering and understanding themselves. Just to kind of show kind of in terms of the labels and diagnosis, Neve's a young person that's in our book. Neve and her mum kind of shared their experiences of being through eating disorder service, through not my eating disorder per se, but through the eating disorder service that I work in. She wasn't actually diagnosed with autism when she was in our service, but as if you read her book, you'll also see that I found that there was something very different in the room. Neve wanted to be vegan, so I let Neve be vegan, which is very strange for my practice, because usually I kind of drill down the veganism. Is it another means to just restrict your eating? But for Neve, it was a lot different. And actually, once I let her be vegan, she actually kind of really got on board and started eating more. And then she met Fiona after that. She came back into services with anxiety and got her diagnosis of autism, and she's flourished ever since. So this is just one of the quotes from Neve about actually being diagnosed with autism, and how actually she's now feeling really confident in who she is and being able to express who she is. I suppose it's also important to kind of consider other kind of areas when you're working with these young people. And we get a lot of referrals with feeding disorders. And I think there's a lot of confusion around what eating disorders are, and I completely understand that. So I'm not going to go through all the different feeding disorders, I'd be here all day, but I want to pick out kind of one thing that becomes a hurdle, and that is ARFID. So that's avoidance restrictive food intake disorder. And a lot of people go to me, oh, they're the young people with autism. Actually, not necessarily. I'm not saying those with autism don't have ARFID, but not everybody with ARFID has autism. And I think that's important distinguishment. So some people with ARFID actually have had trauma that's caused them to not eat. And it's important to do that distinguishment. And sometimes they're not suitable for eating disorder services. Are they better held in community dietetics or with other services, CBT and general CAMS? These are things that we really need to ensure that we're providing the right care for the right, for that person. Also, just because there's anxiety or autism and eating disorder doesn't mean that there's other things at play as well. So Fiona's already mentioned ADHD, but yes, anxiety, depression, emotional dysregulation, all those things we need to also consider as well when we've got a young person in front of them. And I suppose everybody who's working in kind of mental health service goes, oh, this is all very well, but our service or environment that we're working in doesn't actually allow us to do this type of work. Yes, there's like difficulties with pathways and where people fit in and slot in and go down what pathway. But as a practitioner, I always think we should be really open and really curious with each individual that we have in front of us. Yeah, I have my frustrations. It's part of working in the NHS about going, well, this person should be there, this person should be there. But actually, when you've got a young person in front of them and they're struggling, then actually have a conversation with the likes of Fiona, or Fiona has a conversation with me, and what can we do for this young person to ensure actually they've got good mental and physical health. So keep pushing as a practitioner. I suppose this last slide for us is just a kind of generic advice for parents and professionals. My one key thing that I'll probably pick out from this is that stay curious and listen to the young person and their family. It's really, really important. So not like the words are being said, but there's important to kind of delve into the context behind those words. I can't emphasize that enough. If something feels different in it, be curious about that difference. Sometimes we're so stuck on being very manualized assessments, boom, 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 go through the list and walk away, and actually, have we actually obtained the information that we really need? Go off piste if necessary. If you feel that there's something else, then actually go there, ask those questions, because that might be the key bit of information that is necessary. And for families and young people, it's really important that your voice is heard. I suppose that's kind of the key things from this slide that I would pick out. I'm not sure what Fiona would say would be her key piece of information, but I'll pass it over to her.
I think for me, in terms of for you as professionals, I would be saying be brave. You know, Charlene and I have had to, you know, kind of be quite maverick and quite brave and outspoken because we work in systems that often don't work for our young people. So don't be scared to be brave. It is scary, but do it. And challenge the systems, and challenge other clinicians if they're not getting it. So don't let them get away with it. Don't let them not understand. It's our job to impart our information and our experience and our knowledge, and to keep on learning as well. Keep up to speed with what's going on, and share that information. And in terms of parents, be compassionate. We're not in their shoes, and it's very distressing. And often our young people who have autism have had lots of doors closed on them before they get to us, and they've been very misunderstood, and their families have been misunderstood. So always bear that in mind when you're, because there's often a lot of distress and a lot of misunderstanding. So just, you know, let's just try and be compassionate and understand where they're coming from. That doesn't mean to say you can't challenge them, and you'll have some difficult times, but like any relationship, sometimes we need to do that as well. But as long as we're challenging with compassion, then that's okay.
And just in terms of the kind of references that we use, that's these here, if you want to look them up. And of course, there is our book, Autism and Eating Disorders, young people's journeys and reflections, as well as adults' experience as well, and or personal reflections of working with these families. I suppose a note about that we always get an eating disorders is what about the family, and their family is key to all understanding of this, and that means just maybe involving them in terms of understanding what autism is. And I think that is it from us. Thank you very much.
Thank you for listening. Bye.
Bye.
Hey, it's Ian here at Studio TV. Thank you so much for joining us here at Getting It Right for Me Live. Let me ask you a really quick question. Are you here because you are hoping to develop your skills and your knowledge and all your learning and understanding around supporting and caring for children and young people with special educational needs and disabilities? I assume that's what you've come here for. We hope that you're enjoying your time here with us. There's some amazing people and we're so grateful for them coming and being part of this. And we're so grateful for you to be joining us as well. There's a couple of things I just really quickly wanted to introduce you to. First of all, don't forget that you can upgrade your ticket at any time to one of the paid tickets, which we try to keep the price as low as we possibly can, just to cover what we need to help out the speakers a little bit and make sure this event is as good as it can be. What that means is you can access the live Q&A sessions that we're running throughout the event, and you can access all the sessions for up to a year afterwards if you buy one of those paid tickets. Check out the whole school ones. How that works is if you book a whole school ticket, and you can pay online or you can drop us a line and we'll issue an invoice and we'll sort it all out. That's absolutely fine. But we'll then make it possible for all your staff to be able to access all the sessions here at Getting It Right for Me Live this year. So do hope that's helpful. The other thing I want to mention is, and there are lots of members joining us this week, so thank you so much to those of you who are members, but we have put together, if you're looking to go deeper and access ongoing support and help and training, either as an individual, as a parent, as a professional supporting someone with additional needs, in a school or educational setting, or from a professional point of view, we have put together here at Studio TV with Lynn McCann and her team at Reach Out ASC a fantastic membership that starts at just £10 a month and includes a wide range of courses to help you support those in your care. There's a load of resources and tools, printable things that you can use to work with those children and support them. And there's more content being added all the time. One of my favorite parts of the membership is there is a peer group community that's built into that. So you can ask questions of Lynn and her team and your peers, built right into that membership as well. As I say, it starts at just £10 a month. Whole school memberships are there. We're offering trust-wide memberships, and local authorities have started to get in touch and offer this to their staff across a range of schools as well. We would love for you to join our community. If you've got any questions on that, drop us a line, but very much hope to see you there. And thank you so much. Enjoy the rest of the event.